I think an ongoing theme has been, where does immunotherapy fit into sarcoma? It's so exciting to see in melanoma and other studies where PD-1 and PD-L1 inhibitors have had such an impact on disease. Some of the themes that we've seen is that sarcoma, at least most of them, don't seem to have sort of that same response to immunotherapies, at least just standard PD-L1, PD-1. There are several abstracts looking at studies and using immunotherapy, trying to understand, are there specific markers that we should be looking at? Is there a way that we might be able to predict? I think the information is evolving. There have been some studies looking at CAR T cells showing some activity in a subset of tumors that have specific antigens to target. So these have been primarily in synovial sarcoma and myxoid or round cell liposarcoma, where MAGE antibodies or NY-ESO-1 MAGE antigens or NY-ESO-1 antigens are present. And there does seem to be some real activity in heavily pre-treated patients. And I think the question is, as we move forward, what do we do with that information? They are therapies that are more toxic than some of the standard chemotherapy, but certainly we have examples in many other malignancies that a effective immune response can lead to prolonged disease control and potentially even cure. So should we be thinking about moving them in where we provide, should this be in somebody who has metastatic disease? Should we be doing this in the second, third line setting? Or at this point, the limited ability of centers to do this, as well as toxicity, I think it's been relegated to sort of later lines of therapy. And I think we just need to ask the question, is that where it should be? Or as more individuals and centers become comfortable with doing CAR T-cell therapies, is there a role for doing them earlier on? So I think that's one theme that's out there. I think another theme, and this is one that's not necessarily new, is, are there ways of predicting based on tumor biology, specific markers within a tumor or other markers that a patient may have, their degree of white blood cell count elevation and things like that, that may be markers for whether or not they're going to respond to therapy or not. And particularly when you're using toxic chemotherapies, figuring out, is there something that we can provide that's effective and meaningful to a patient and avoid giving it to patients who are just going to experience toxicity, is a constant theme. I think in sarcomas, another theme that arises is that many of these tumors have very specific biologic translocations or mutations. Are there therapies that we can use that specifically target that? And I think the classic example is GIST, where, over 20 years, we've really defined how to use targeted therapies. But there are some smaller diseases or much less common, rarer diseases where there are some studies that have been looked at. So I think sarcoma is very unique. And I think sarcoma has just many different types of diseases, some of which are characterized by very specific genetic changes that can be targeted. And are increasingly being tested as we have additional agents to try.